Welcome to the podcast. I'm joined once again by Professor Eduardo Kattan. And now that we have heard the scientific overview of Andromeda 2 shock trial, we'll shift into a dialogue focused on practical impact at the bedside. So, Professor, the first question obviously it is why Andromeda 2, the clinical rationale. Which limitations of Andromeda 1 shaped this trial, and what core clinical questions motivated Andromeda to? Was there a specific bedside dilemma or subgroup that drove the design?
Yeah, it's a wonderful question. I think that after we finished the Andromeda 1 trial, we started thinking on how can we try to improve resuscitation, but because now we have a target, let's say capillary refill time, that's cheap, it's simple, it's bedside, it's costless, and it's non-invasive. But how can we bring this simplicity into the other side of the coin? That's how we tailor our therapies, trying to do a really personalized approach on resuscitation and not, let's say, going restrictive versus liberal or high versus low. That was our core motivation, trying to find the same simplicity we found in capillary refill time into this aiming at personalization.
So, when we talk about the physiologic logic, why capillary refill time, personalized hemodynamic resuscitation? So, why CRR, that is capillary refill time over lactate? What is a stronger physiologic basis
Hmm.
when it comes to the Andromeda CRT versus the lactate? Is lactate
Yeah,
more of
that's
a marker of stress or metabolic depth than perfusion?
on one side, that's actually true what you're saying, that lactate is a signal that's, let's say, confounded by some aspects. For example, adrenergic stimulation, liver failure, et cetera, and also the kinetics of lactate through resuscitation shapes like a bimodal, let's say, uh,
It's not a
drawing
linear
or
one, it's a
curve.
curved, yeah.
Yeah,
It's
no,
curved.
yeah. So probably if we still chase lactate in this second part of the curve, we're probably submitting patients into a burden of over resuscitation and more interventions that we know that sometimes are toxic or could have adverse effects. And capillary refill time, let's say, is a very sensitive marker that's determined probably by skin blood flow. And when the patient is under stress, this flow will be diverted from the let's say, non vital organs and will be uh, taken away. So what we're seeing in the skin, and there's a lot of literature on this, is also happening in the intestine or in the microcirculation. So there's some nice studies correlating cap refill time with microcirculatory blood flow or uh, abdominal organ flow. So it's like a canary in the coal mine that is alerting us that we're having hypoperfusion in relevant territories. And also the kinetics of response of capillary refill time are quite impressive. And there's a study in France by Lisa Raya that showed that after 15 minutes during a fluid challenge, we see significant changes on capillary refill. So I think there's on CRT, there's a big corpus of evidence with that assesses not only increased odds of like a prognostic variable, but also that can help us track changes on the cardiovascular physiology.
So, is it a time to say bye bye to lactate, or still lactate can guide us in certain subgroups?
Yeah, no, I completely agree with your second. I think that we should use all elements of of judgment to make better decisions. And probably lactate will show us a trend. If the lactate is improving, you're going in a good track. But capillary refill time will be probably faster to take faster decisions. I always tell my residents that it's like if you're seeing a patient with diabetes, you'll see the glycated hemoglobin that's lower, but you do the glucose
You the
strip.
you do
Yeah,
the
like you
PTCT.
have faster information. Yeah, so probably they're bringing complementary information to taking decisions.
So now let's come to the Andromeda trial. So how do a combination of CRT, pulse pressure, diastolic arterial pressure, and basic echo together help classify hypovolemia, vasoplasia, and cardiac dysfunction? So what made you bring all these three into one category and help us in classifying hypovolemia versus vasoplasia versus cardiac dysfunction?
Yeah, so the first, let's say, branching of the tree on our protocol is done by pulse pressure. And pulse pressure is a nice surrogate of stroke volume. It's cheap, it's simple, and it's bedside. And pulse pressure is determined by aortic compliance and stroke volume. So with a low pulse pressure, you're probably having a low stroke volume, and then we test fluid responsiveness. So then we can assess if the patient is actually preload dependent or not, and and give fluids accordingly. So if we find a patient with a low pulse pressure and fluid responder, she's probably requiring fluids and hypovolemic. On the other hand, if a patient has a normal pulse pressure but a low diastolic blood pressure, diastolic blood pressure will be determined mainly according to vascular tone and heart rate. And there's a nice paper by Professor Ospina that he mixes these two and called diastolic shock index. And these patients are broadly vasoplegic. So in this sense, what we're aiming here in this, let's say, other subset is to increase vascular tone through vasoactive drugs and avoid giving fluids if they are not required. And if any of these two big interventions fail to identify or to restore capillary refill time, we come to the beginning of tier 2. That's a basic cardiac echo to rule out right or left ventricular dysfunction. So with these three interventions, we can check these big, let's say, patterns or phenotypes that we were talking about.
So it's amazing. You covered all the things. You look whether the patient is hypovolemic, or maybe the vasoplegia is playing a role, or maybe it's a cardiac dysfunction, and accordingly you precisely decide about the therapy of the patient. So very well planned. But how reliably can these macro phenotypes be identified without advanced monitoring? Is there any role?
I'm sorry, without advanced monitor or with?
Without advanced monitoring.
Yeah. So what we have is we published last year or this year preliminary data, and we found that pulse pressure at least has a very nice specificity over 90 to identify a low PTI with a cardiac echo. So we cross-checked uh, pulse pressure and stroke volume through echo, and we found that it has a big specificity. And also the diastolic blood pressure signal. There's a study by, I told you, Gustavo Spina Tascon, that assessed this relevance, and also another one by Professor Teul that he used an acronym called VNERI to assess vascular tone and responsiveness to norepinephrine. So at this sense, I think that even though they're not perfect tools for a first approach, and we must remember that usually we do not have access to echo at the beginning of resuscitation, and we do not have access to, let's say, cardiac output monitoring at the beginning or during early resuscitation. So these simple bedside tools can help us sort out, at least in this protocol, 63% of the situations and normalize capillary refill time without using an echo was required only 1 out of 3 patients. So this is the nice thing of the study, I
So
think.
very, very well said. But when it comes to the capillary refill time, we all are aware of the variability. It varies as per the skin color, tone, and also the technology. So how do we address this inter-observer variability and training needs?
Mm.
And what was the variability seen in the Andromeda 2? Was it checked also? Or was there a variability there? Were you
We,
looking
we did
for?
not we did not check actually, but we trained a lot the participating centers on how to do the technique, and we trained them with videos, material. We did some, let's say, initial standardizing phase. So, and we were always there for them, and also we dichotomized capillary refill time. Let's say it was normal or abnormal, also to simplify the practice. We did not, let's say, go from 5 to 3.4 or 5 to 3.2. We say, okay, over 3 is abnormal, and even though they did the standardized technique, there's always space for interrate variability, right?
So what is the preferred measurement site for the dark-skinned patients? As it's
That's
difficult to look into the dark skin patients. So any preferred site?
that's a good question. Um, that's an actually a great question. I know there are some studies that have tested in the tip of the nose, the earlobe, or in the sternum.
Forehead as well.
Yeah, and forehead as well. Yeah. So this is a way to in patients with darker skin that in the fingers could not be easily trained done.
So as you showed us the algorithm, that is the pillar one, pillar two, pillar three, pillar four. So how do reversible tests like MAP challenge, low dose dovitamin improve personalization compared to traditional fluid challenges or mixed mean arterial pressure targets? So uh,
That's a wonderful question. And if you see in the supplement of the study, we showed that a minority of patients required the MAP test or the dobutamine test. And only from the 700 patients randomized to intervention group, only 60 required the MAP test. And from those 60, 50% normalized capillary refill time with intervention. And from the dobutamine test, only 40%, no, only 40 patients, 43 patients required the test itself. And as well, there was around a 40, 50% response rate with a normalization of capillary refill time. So in this sense, these tests are for the micro titration of the final part of the protocol,
okay.
but it has a chance to improve CRT in around 40, 50%.
Oh, that's a very good number, I would suggest. Uh, when you talk of the diastolic arterial pressure, it's quite a bit of under recognizing, I believe, because the classically we have been taught to look after the map. All guidelines, be it the sepsis guideline by SICM or the sepsis group, they all talk about the map. But here, very well, we have spoken about the diastolic arterial pressure. So, is it something which is under recognized resuscitation target in vasopedia? And what is the interpretation
Yeah.
of the success rate of DAP augmentation of more than 50 millimeter of mercury?
Yeah, that's also, I think, DAP is the forgotten brother of the mean arterial pressure, or the forgotten sister of the mean arterial pressure. And actually, it's a signal that we're looking at vasoplegia, and probably increasing vascular tone could enhance not only flow, arteriograph flow, but also coronary perfusion. And in this sense, in the study, 120 patients went to the DAP test or to the DAP augmentation, and only 20% in normalized capillary refill time. So it was a little bit, we found it a little bit insufficient compared to the other tests. But when you see the raw numbers, when you see the absolute decrease, capillary refill time decreased a lot from 7 to 4. The problem was that it did not reach the threshold of 3 that we categorized normal to abnormal. So right now we're running some post hoc analysis to see the true value of these tests, and I hope we can have them soon finished. But we're still is under construction.
Yeah, amazing. Would be interesting to have a look at that data as well. So also I went through the study. What I found was the dovitamin use was increased to 12.3% versus 5.3% in mean myocardial dysfunction. So should low dose dovitamin testing be routine? Is myocardial dysfunction being under recognized?
I actually, it's interesting because if you see that the vitamin was increased in the protocol, it was after excluding patients that had cardiac dysfunction, and this dobutamine use was probably trying to not mainly focus on cardiac dysfunction, but to open the microcirculation. You know, there are some papers by Daniel Debacker that show that dobutamine increased the mean flow index of the microcirculation. So in that sense, this low dose of vitamin has this role of, let's say, restoring the microcirculatory blood flow. This dual role, not only on the cardiac side.
So, when it comes to the septic shock, we look into the perfusion markers and we always look into the one-hour bundle where we talk of the vasopressors versus fluid. And also, eventually, longer term, we also look into the early deresuscitation as well. So, how did CRT PHR influence fluid balance? What was the difference in vasopressor patterns between our arms? And did actually CRT PHR accelerate deresuscitation and reduce edema and improved SOFA score faster?
Yeah, it actually improved SOFA score faster from 7 days, from day 1 to 7, had a steeper decreased trend. And patients received overall less fluids, had lower fluid balance, and had lower CVP. But this actually spreads a lot when you see those that are normal or abnormal capillary refill time. So I think there was a nice group that were patients that had a normal capillary refill time. Those almost received nothing, no fluids, and those patients we just were observed. So what we're seeing is that we're tailoring the therapies to those that actually required it because they had hypoperfusion and were fluid responsive, But those that were not fluid had a normal CRT, basically we didn't even test for fluid responsiveness in these patients.
So the major message of the trial was to stop resuscitation with the fluids early once perfusion is normalized. Is that right?
Yeah, I think that is when we have a normal perfusion, tissue perfusion, let's stop all interventions that can bring more harm than good.
So amazing. And so next is when we talk of the Andromeda 2. So how does Andromeda 2 now fits into the CRT PHR that is differ from Andromeda 1 uh, classic and also the 65 trial where the blood pressure targets were different?
Yeah, I think that the 65 and the classic bring this question of or sepsis PAM, bring this question versus low versus high or restrictive versus liberal, and it's a more rigid approach because, for example, if you have a patient with a pneumonia with a let's say diastolic dysfunction and 80 years old and in dialysis and gets to the liberal arm of fluids, probably will get a lot of harm. Yet a young patient with a peritonitis and goes to the restrictive arm will probably also get a lot of harm. So I think this personalization within the protocol tries to tackle this the effect of the heterogeneity of our syndromes,
So
and that's the growth we did from Andromeda 1 to 2 to try to personalize within
personalized.
the heterogeneity.
So just an extension of this. So should 65 still be universal or the map challenge what we could see in the Andromeda to improve CRT in nearly half of the hypertensive patient? So does it say we should individualize map in hypertensive rather than using a blanket 65 target?
It's an interesting question, and you're aware of the OPT-PRESS trial that was published recently in ICM,
Yes.
in which a high map had deleterious effects and brought an increase in mortality. So I think that uh, when initial resuscitation fails to improve uh, tissue perfusion, testing for 1 hour helps us check if there is a positive response. And we showed in a trial that in an observational study, we saw the effect of this increasing MAP into capillary fill time. And there were some patients that improved and others that worsened. And it was similar to what Professor Dubin showed by increasing MAP and checking the microcirculation under the tongue in 2009 in critical care. And he showed that there was an heterogeneity of response. So this time frame of 1 hour allows you to check if the intervention helps tissue perfusion. If it doesn't, you can go back. So you don't expose patients to inappropriate catecholamines. So I think that's the beauty of this test.
Beauty of this test. So as we went through the data, we realized CRT normalizes faster, that is 86% almost versus 61% with the usual protocol as compared to the PHR. So we all understood CRT is the earliest actionable perfusion marker in real world practice. So what is the message to clinicians who still distrust CRT? They don't believe in CRT as yet.
I would tell them to test it, to check it, and to see it at the bedside to create their own idea and see how resuscitation moves with the patient, how the different tissue perfusion variables move to make their own corpus of evidence if they do not, if they're, let's say, as skeptics of this technique, and also to integrate it to other, not to use it as a sole marker of tissue perfusion, to integrate it with central venous saturation, lactate, and you'll see how it moves and check.
And also, how do ICUs adopt CRT PHR, that is capillary refill time, personalized hemodynamic resuscitation, considering minimum competencies as related to the CRT technique, echo basics, pulse pressure, and DAP interpretation, and also the fluid responsiveness? So, how do
Yes,
ICUs adopt CRT PHR?
I think that I want to be completely honest here, and I think that uh, this is at least how I see it, and trying to be very, very, very fair as well. This is the starting point for personalization. I do not know if this will be the rigid protocol that will be here in 10, 15 years. Probably it's super contextual to what you can do at your unit. For example, if you're an expert in echo, you'll probably try to phenotype the patient early, and if you have an echo at the bedside 24/7. If not, let's say it becomes more difficult. But at least the key actionable nodes, that is checking pulse pressure, checking cap refill, checking fluid responsiveness are routine practice that we can do at the bedside. But I think the key message or the core message is that if you personalize therapy here during resuscitation, you probably target better outcomes if you're looking for not only targeting macro numbers, let's say map of 60, cardiac output of 4, but checking also tissue perfusion.
So were certain phenotypes early versus late responders? Could you identify those? And is phenotype guided
That
resuscitation the next frontier?
that's an amazing question, and we just received the database, so we're starting to
Looking.
scramble around the numbers and checking the for the results for this kind of questions. So I hope that we can have a let's say if the hypovolemic responded earlier or the those with cardiac dysfunction were the worst. So we're addressing these
Hypertensive
questions
patient with the
that
late responders where you had to get the mean up further.
yeah, those are amazing aspects that we should address, and it's a lot of work we're going to have this 2026 to bring up these clues. And regarding phenotypization, yesterday or the day before yesterday, there was a nice paper in JAMA published, the Immunocept trial that also was positive, and they were targeting molecular targets for immunoparalysis or cytokine storm, that also in the same line of phenotyping, trying to tailor therapy and trying to tackle this issue that septic shock patients, as well as ARDS, there's a big bag of heterogeneity. So if we understand better the subphenotypes or the clusters, we probably will give more rational therapies.
So in recent time, I always say it's an era where initially we used to proudly say my ICU is protocolized ICU. Now we are moving towards where I say my ICU is no more protocolized. It's a personalized ICU. It varies from patient to patient. So we're coming there nearly. So when you talk of this, the key takeaway. So one practice would change intensist should adopt tomorrow morning, or one sentence correction for the biggest misconception in perfusion targeted resuscitation you would like to clear.
Yeah, that is not I think one concept here is like if tissue perfusion is normal, let's say capillary fill time, lactate is decreasing, you're okay, and just avoid doing more stuff because at the end of the day, we're bringing adverse events, fluid overload, catecholamine excess, and try to uh, just watch full waiting for the patient. I think that's the main message. Sometimes less is more.
So, Professor Carton, thank you for your time. It's an amazing trial and it's really reinvented the wheel. And I believe, as you said, maybe next 15 years, we shall be following this personalized cares. And 2026 will be interesting to keep an eye on you as you will come up with more
Yeah,
and more data and the questions will be answered. The clarity you
yeah.
brought to the Andromeda 2 findings, we truly appreciate your expertise. Thank you very much. And your
Thank you
insights
for
will
the
definitely,
invitation.
yeah, your insights will definitely guide bedside practice. Thank you.
And just like a small message, probably this protocol, I hope it's the starting point. It's not the definitive way to do it. Maybe we can get it better, we can do it better, but it's a starting point, and we're very excited about not only the results but also the journey itself. These 4 years have been amazing. A lot of personal growth, a lot of friendship. As you know, the study was done without any funding, so there was a lot of passion. There was a lot of push from many people around the world, and we
86
are
countries.
quite indebted. 19 countries, 86 centers. And these are the true heroes of the study. I just
Thank
want to
you.
say thank you to all the participants, all the people that made this possible. More than 800 uh, collaborators around the world that were recruiting patients at 2 a.m. in the morning. That's amazing. And just moved by the idea of giving a better care with the patients with septic shock.
Thank you very much. Thank you for your time, Professor Carter.
Thank you for the invite. Bye bye.
Bye bye. See you.